This is In the Bubble with Andy Slavitt. This is our first show in front of a live audience in Aspen, Colorado. Today, we will be talking about healthcare. Let me say first a big thank you to Aspen Ideas Festival, the Aspen Institute, for hosting this event, and the audience. Speaking of which, you all will have a chance to ask our guest questions at the very end of the show, so be ready. Now, Medicare is relevant to everyone in some very obvious ways and some non-obvious ways. The obvious way, we all pay into this program our entire working lives, and we count on it when we need it as we age. And along with Medicaid, it is the single biggest poverty reducer in the country. Less obvious, Medicare influences many of the things about healthcare that we experience every day, the decisions that get made that affect all of us. What things are covered? We often wonder, why is this thing covered by my insurance and why not? How much doctors get paid? How doctors get paid? And everything from the crutches that you get, to the therapist that you need, to the rehab facility, many of the decisions on how all that works have their roots in decisions that get made by Medicare. Certainly, if you're looking for one person to blame for your complaints about the healthcare system, you could do worse than my next guest. Now, certainly, I think you will find that my next guest is not to blame at all, I hope, for the things that ail you about the healthcare system, and in fact is working on those various things. But we'll get into that. It's a lot of responsibility. And it's also the largest place where our taxes go. More money goes to provide healthcare through Medicare than goes to the Department of Defense. And because of all of this, the decisions made by Medicare face an awful lot of scrutiny and an awful lot of lobbying. So my guest today is the woman who runs it all, Dr. Meena Seshamani. A very good applause moment. I guess I don't yet blame you. So we're going to talk about some big decisions that Meena and Medicare are facing. And let me just name a few that may be on your mind today. How and whether weight loss drugs will be paid for. How we plan to pay for big new things like Alzheimer's medications. And the new crop of very expensive medications that could be game changers in treating cancer and many other illnesses that will follow. And we will talk about something that America is about to do for the very first time: negotiate with pharmaceutical companies the cost of prescription drugs. If you wonder who is leading the charge in that negotiation and in that process, it is in fact my guest today, Dr. Meena Seshamani. So we will get into all of that stuff, but first, how does one get themselves in the position to run Medicare? Tell us what makes you tick.
Well, thank you, Andy, for having me here, and thanks to the Aspen Institute for having me here today. So my background is a physician. I'm an ear, nose, and throat specialist, and I'm also a health economist. And I think I have had the privilege and really an incredible opportunity to bridge those worlds through what I've done with my career, where I've taken care of patients at the bedside. I have seen where the healthcare system works and what a profound impact those of us in healthcare can have on people's lives in a very real, tangible, and lasting way. And when the system doesn't work, how tragic that can sometimes be. And you know, Andy, just to give an example, so you and I worked on the Affordable Care Act together. I don't know if you know this story, actually. So after you and I worked on the Affordable Care Act together at Health and Human Services, I went back and was practicing medicine again as an otolaryngologist, which is an ear, nose, and throat surgeon. And I had a woman come into my office with a mass on her neck that was enlarging. And I examined her, and I was pretty sure that it was thyroid, and the speed at which it was growing, I was pretty sure it was cancer. And I said to her, okay, we're gonna get some imaging, we're gonna get a biopsy, figure out what this is, and she told me, well, my health insurance only covers office visits and prescription drugs. And so she was a temp worker, like an admin temp worker. And
that's freedom.
Yeah, and I said, okay. She said, so I can't get that done. And it was October, and I said, okay, in November, it's going to be open enrollment for Obamacare. So I showed her the DC HealthLink website. I said, I want you to go onto DC HealthLink. I want you to get a health plan, and then we're going to take care of this. And so I followed up with her, made sure that she got an Obamacare plan. She did, got the biopsy. It in fact was cancer. I referred her to one of our specialists, and she had her thyroid removed. And I think that's just an example of how we talk about these heady policies, right? We talk about, you were saying how Medicare is the largest payer, right? $1 trillion in claims, it's more than 64 million people. All of these numbers represent real people with real issues, with real opportunities in their lives. And that's what motivates me in this role that I have now. How can I serve all of those people so that everybody can have a fair and just opportunity to achieve their optimal health?
So let's go back and talk about the 64 million, but I want to go one step further back in your background. So you're an economist and you're a surgeon. Either one of those things seems a little difficult. But you are both of those things, and by the way, a health policy expert, and you've been a healthcare executive at a major health system. How does that happen? Like, just give us a little bit of when you were a little girl, were you saying to yourself, I want to be a health economist, and I want to be a surgeon. Why pick? Like, how did this all come to be?
Well, no, it definitely was not some planned out from age 4. You know, just through childhood, I volunteered in hospitals and really liked that interaction with people and the ability to impact lives. And I think just through my journey, it was really about what are things that motivate me, inspire me, and enable me to feel that I'm making a difference. So I initially thought that I was going to be a full-time practicing pediatrician. That clearly did not happen. I did my surgery rotation. I absolutely loved surgery. And similarly, I thought I was going to be a bio major. I did an Econ 101 class, loved economics. So I think a lot of it was just keeping my eyes open and my heart open for what opportunities presented themselves where I saw, hey, this is an area where maybe I could make a difference in this world, and just rolling up your sleeves and making it happen, and working with a lot of amazing people along the way.
Okay, so you did some pretty amazing things, which I think I will get to in a second. I think make you very well suited for this moment, particularly the moment of negotiating prescription drug costs. Someone who's both a physician and an economist, it seems like right place, right time, at least for all of us, that you're here. But I want to maybe just start on the Medicare program itself, your responsibility. Now, the Medicare program has gone through iterations since 1965 when it started. It started as a hospital benefit and then outpatient benefit. It added some things over time, including prescription drug coverage in the early 2000s. It has both a public and a private component to it now. So it has evolved, maybe not with the times, but it has evolved to reflect at least Congress's view of what needs to happen next. Give us the modern vision for Medicare, the program over the next couple of decades. How should we be thinking about the vision for what that program should be and should mean and what it's all about.
Yeah, well, I'm going to pick up on something you said, Andy, about how the program evolved to reflect the changing, times, changes from Congress. And I would say moving forward, and certainly this is how we are viewing it and how I'm viewing it, it is evolving to drive changes. I think that especially through the pandemic, we have seen where the healthcare system is broken. And I think the Medicare program stands to really drive a lot of the changes that we want, all of us, out of healthcare. We want to be cared for as people, not treated for our diseases, right? And so through the Medicare program, where can we create models of care where people aren't just someone who comes into a doctor's office with a specific diagnostic code that the doctor will document, that then has a service done that's a specific claim that then provides a specific payment. But instead, here's someone who has healthcare needs, who has things going on in their community that impact their health, that we as a society and as a healthcare system want to take care of. And so I think, through the various parts of the Medicare program, because as you mentioned, some people choose our Medicare Advantage, which is where Medicare partners with private plans. Some people choose traditional Medicare. There's prescription drug coverage. Ultimately, what is all of it about? It is about providing better care, improving health, and spending the Medicare dollar in a smart way so that we can really drive those improvements in the healthcare system and for real people.
Can you talk a little bit about that tension that exists between the last thing you said, the healthcare costs, and the care that people feel like they deserve, as whether in the Medicare program where people have paid in and feel like they're entitled to certain benefits that are promised to them, or the spillover effects to the rest of us that aren't yet in the Medicare or Medicaid program, but also insurance companies make these sorts of decisions. You have to balance this incredibly precarious thing. There's something called the Medicare Trust Fund, and it has to have enough money in it to pay the claims, and Congress has to be allocating money in order for that to happen. We spend a lot of money on these programs, and yet people want more. Seniors want dental care coverage, they want vision covered, they want more mental health care coverage, they don't want to see their doctors underpaid. So help the person who's sitting out there going, yeah, I'm one of those 64 million people, and I don't really feel like this system is set up for me. I feel like it's run by either a managed care plan or by some government official who doesn't really appreciate these needs and is maybe even trying to save money at my expense.
Well, I'll pick up on what you said, Andy, about the saving money at my expense, because I actually think it's the reverse. If you can keep someone healthy, you prevent that hospitalization. And who really wants to be sick, right? Who wants to be in that hospital?
Okay, but let me challenge it. What are we doing to keep people healthy?
Exactly. So I think, that's where being able to invest in preventive care, being able to think about what are the various things that impact people's health. I'll give you another example. In my prior role, I led care transformation for a major health system. We had a woman with chronic obstructive pulmonary disease, so lung disease, who came into our ER 17 times in like 3 months. And we were wondering what is going on for the lung disease. And we had a community health worker go out to her house. And it turned out that her electricity was getting shut off because she wasn't able to pay her electricity bills. And so her nebulizer wasn't working. And so that's why she kept coming back into the emergency room. So the community health worker worked with the utility company, right? We got the electricity issue fixed. She stayed healthy and she didn't come into the emergency room. That's an example of where you can keep people healthy and it actually saves money and actually spends money in a smarter way. So I think that's kind of what I would say. And we'll talk about this with prescription drugs, where if people can afford and take the medications that they should take, that can keep them healthy and can prevent all of these issues down the road.
So I will grant you that we all believe in that. I think we all believe staying healthier reduces costs in the short term. But there are clearly other examples, unlike the example where people are overusing the emergency room because a small problem hasn't been solved, where, for example, someone will have a late-stage cancer, and there's a very expensive drug, or someone will want something diagnosed because they think it may be missed, and Medicare says, you know what, you're not entitled to another diagnosis yet, because that diagnosis is adequate, but their doctor may be telling them something different. So we all know we run into those situations where we have a limited budget, and those rules have to come into effect somehow, and we don't know where they come from. Some come from Congress, some come from Medicare, but how should we philosophically be thinking about those trade-offs? How do you think about those trade-offs?
Well, actually, you raise a very good point, Andy, and this is something that I have a tangible example for what we have done, because I think ultimately what's important to us is that people are able to access the care that they need. And it came to light for us. This is in the Medicare Advantage program, where we partner with private plans to provide Medicare benefits. And a lot of people have had difficulty accessing care because there were all these hoops that they had to jump through. The technical term is prior authorizations.
Ooh, we love that term, don't we?
Prior authorizations, where the physician has to get approval from the insurance company to be able to provide a treatment. And this was something that we have heard about from patients, from providers, from experts in the field, and also from health plans, where they're like, well, we need clearer rules of the road here. And so recently we made some pretty significant changes saying to health plans that if you have these kinds of protocols in place, they have to be well established, publicly available, following clinical protocols that are reviewed every year. You have to have clear paths for appeals, et cetera. I mean, these are the kinds of things that we are constantly iterating on because it is so important to me. I will tell you, I had to deal with prior authorizations when I was practicing, right? So things like that the physician the clinician on the health insurance end should have relevant expertise when they're making a decision about whether a treatment should be covered or not, right? Some of these things, it's really thinking about common sense, right? And really trying to constantly embed that in our programs.
Are these, in your mind, things shared among Democratic and Republican administrations, or are some of the things you're saying, which I think do sound pretty good to people, specific to a philosophy that comes from, say, a Democratic administration?
I view very much that what we're doing is really about the health of people. That's not a Democrat issue or a Republican issue. You know, two areas that are prime priorities for me and for the Medicare program, rural health and behavioral health. Those are issues that span blue, red, right? Where, we have done so much in trying to bring more providers to be trained in rural and underserved areas, because where people train, they learn the needs of those communities and they're more likely to stay in practice. We are expanding behavioral health, like what providers can work with the Medicare program, mobile vans to bring opioid treatment to people in their communities. We all know that rural and tribal areas have been decimated by the opioid crisis, and people can't drive hours upon hours to go to a treatment facility, so we are paying for vans to come to them. Those are not partisan issues.
Okay, so we're about to enter a new era, an era where prescription drugs are going to be negotiated by Medicare with the prescription drug companies. So as we get into this topic, maybe help Americans understand what's going to change that they're going to see and when.
So this Medicare drug price negotiation is part of the new drug law, the Inflation Reduction Act, but we'll call it the new drug law that was passed last August. There are three main buckets to that law that I think people will see the impact of. Number one, there are changes to the Medicare prescription drug program. Some of this has already gone into place and has literally been life-changing. Starting in January, people with Medicare can get recommended vaccines at no cost to them out of pocket. So people were previously paying sometimes $200 for a shingles vaccine. Now you don't pay anything. Insulin, no one pays more than $35 for a month's supply of an insulin covered by a prescription drug program. I will tell you, Andy, I led our diabetes management pathway when I worked in the health system. The number of people who could not afford their insulin, and that was the reason that they were so sick all of the time. I had one woman tell me that she was paying for her brother's insulin because her brother couldn't afford it. Like, this impacts not only the people with diabetes, but the communities and the families in which they live. That went into effect in January, and insulin pumps goes into effect July 1st. In another big issue, in 2025, no one will pay more than $2,000 out of pocket in a year for prescription drugs, which is huge also.
How much are some people paying today at the high end?
Oh, thousands upon thousands of dollars. Because right now there's no limit to what people pay. $8,000, $9,000, I mean, it can go up. So that's huge for people to being able to access.
Right. These are people on fixed incomes.
Correct,
yes.
Correct. And people who are oftentimes on multiple medications, right? So that is one bucket. Real tangible impact for people. The second bucket is something called the inflation rebate. You gotta love the really sexy terms that, that our policy wonks have. Basically, drug manufacturers have been able to increase prices over the years. Now, if they increase drug prices faster than inflation, they have to pay the difference back to the Medicare program. So that will discourage the runaway price increases that have been happening.
Yes, and I recall when we were at CMS, there were literally hundreds of drugs every year that were priced double-digit price increases.
Yes.
And so we made a decision to say, because we didn't have this law, we were going to publish a file every year saying every drug that increased its price by 10% or more, many of them were just under the radar, we were going to publish publicly. And the next year we had an amazing number of drugs that increased by 9.9%. Funny how that works. So, moral is, people will price what they can get away with. And that's a huge, even if it's a more difficult thing for people to comprehend, that will keep costs more manageable.
Yes. And then the third bucket is the drug negotiation. So in January, we put out, here are the steps we're going to take to set up this drug negotiation program. So there are various guidances that we are putting out, data collection requests. We're really getting input from everyone. Because as you said, Andy, I mean, this is historic for Medicare to be able to negotiate. Previously, the law, I think you had mentioned before, right? There are certain things in Medicare law, and in the Medicare law, it had said that Medicare could not negotiate. Being able to negotiate is an important part of how a market works, right? With anything that we purchase in our economy. And so to be able to negotiate, I think presents a huge opportunity for us to really drive the conversation of what benefits do drugs bring to the health of our populations and what do we pay for them. So we are working with patient groups, drug manufacturers, healthcare providers, academic experts, pharmaceutical manufacturers, health plans, everyone, because this is an area that's really ripe for change, and we want to capitalize on that opportunity to really drive positive change in this area.
Now, are you both setting the rules for how the negotiation will work and taking one side in the negotiation? Isn't that a bit problematic?
Well, what we do is, by setting the rules of the road, it's basically things like the law gave us certain factors that we have to consider when we are negotiating. And what we say in this guidance is, how are we going to think about those factors? So, for example, the factors include things like, what benefit a drug provides. What are the costs of production? What kinds of patents the drugs have? And what we have put forward is that the foundation for us is going to be the clinical benefit that drug provides. Because ultimately, that's what matters, right, for people. So being able to think about, does this drug address a need in our communities that has, to date, not been met? So will this really make a meaningful difference in people's lives?
So let me clarify just to make sure that I get this right. So if I'm a drug manufacturer and I make a drug for rheumatoid arthritis, and if that drug looks exactly like or very similar to drugs that already serve rheumatoid arthritis, you may you will factor that into the price negotiation and presumably not give me much more. If I create a drug and I can prove to you, because I have data, because you got to go through trials to get to the data, that there is a increased clinical benefit of 10 or 20%, does that mean you will, in effect, metaphorically, pay me 10 to 20% more?
We will take that into consideration. And you mentioned the data through the clinical trials. This actually goes well beyond the clinical trials. And I think that's an important point, because again, fancy wonk word, randomized controlled trial. Fancy wonk word means this is not necessarily how things work in real life, right?
So phase 4.
Yeah, right? So how does a drug actually work in real life when people are trying to take this drug in their home? Maybe they're on 15 other drugs, right? Maybe it's something that has to be taken at exactly a certain time, so many times a day. These are all things that now we can actually take into consideration.
So you're gonna require, people are going to have to put together real world evidence.
Yeah, that's exactly, real world evidence. And this is something that we've been working very closely with the FDA on. So Commissioner Califf and I work very closely together because this has always been a priority for him as well, right? How do we actually exit the very scientific world to then see how things actually play out in the real world? And I think a lot of us know that the real world oftentimes throws you curveballs, right? And that's something that I think is a really huge opportunity for us, so that we can see, how does this drug meaningfully improve people's lives? How does it address the needs of different populations? And that'll be the foundation.
So let's talk about how this is going. Has there been much opposition or controversy or criticism from the drug companies as to how this is proceeding?
Have you read the news?
You mean the lawsuits?
So, we have worked really hand in hand with everyone. We have, from the time the law passed in August, I have met with pharmaceutical companies, with patient groups, with healthcare providers. Ultimately, my job is to implement this law in the most thoughtful way possible to bring the most benefit that we can.
Maybe you could tell us the points of discussion, controversy, et cetera, that we're hearing the most about. Where are people saying, there might be an unintended consequence, or I have a concern about this?
So, and I will say that a lot of it comes back more broadly to what have been issues in the drug market. That a lot of people are like, this is an opportunity for us to improve the way that drugs work, the drug market works. So there have been issues of transparency, right? How do all of these various, factors come into play when when innovative therapies are coming forward, when they're being priced? That's one bucket. Another is the issues of access that have plagued everyone, for patients who can't get their medications, to manufacturers who put forward some drug, but if someone can't pay for it and obtain it, then they're not,
So you're giving me the defense against the controversy. I want to know whether they're legitimate or illegitimate, what are the pharmaceutical companies saying about, so for example, are they saying this is going to hurt innovation? There won't be enough money in creating a new drug, so I'm going to create fewer drugs? Are they saying that small innovations like a better delivery mechanism, we're not going to have as many of those? Are they saying what are they claiming, or what are you legitimately worried about not being unintended consequences?
So you have read the news.
Well, I've been trying to get it out of you the last few questions.
Yes. So yes, I think there has been a lot of talk about innovation, and is this going to harm innovation? I think this actually drives innovation for the cures and therapies that people need. It comes back to what we were talking about, Andy, with where we want to ground this in what benefit does this drug bring to people. There are plenty of, you mentioned where there's like a slight change on a drug for something that's already in existence. What does that ultimately bring to a community versus something that is a jump, that addresses an unmet need or really addresses a big barrier, an issue of something that's very complex for someone to take versus something simpler for someone to take? That's what we're really driving at. And we want to drive innovation in that way. And I will say that there are many who say that's also, ultimately, why do people go into healthcare? Because they hopefully do want to help people. And this is a way that we can really drive that market in that direction. And
Yeah.
I will say, it is interesting also when you see Bayer just announced that they're investing $1 billion in research in this country. There is the venture creation firm that was behind Moderna. They have created a new startup for research in the U.S. So innovation is definitely alive and thriving.
Look, I've been a very outspoken advocate for this change for a long time, including being on the edge. So I think this is a change we need. I think it needs to be implemented well. And by the way, just for kicks, do you talk about the bottom lines, what the bottom line looks like at some of the largest pharmaceutical companies?
Yes, well, I think last year they had record profits.
We're talking like $20 billion of profit.
Globally, we're talking trillions.
Yeah, no, but for a company. So do they have money to invest in R&D? That question I think we can take off the table. But it's not so simple. Biotech companies rely on biotech investors to buy their stocks when they have a promise of a drug. Those biotech stocks, for example, have to be based on a premise that there's some market afterwards, and there is some legitimate concern, even though not every drug is going to be part of negotiation. There's some things that are accepted, but there's legitimate concern that overall people will just be less inclined to want to invest in some of these long shot cures and ideas. And so, we have to figure out how to balance that. And there have been, because the pharmaceutical industry is a little self-interested, there have been some third-party analysis which has shown that there will be some marginal decline, I think, in the amount of new drugs produced or new innovations produced. Is that right? What does independent data say happens?
Well, I think some of that also comes to what you were talking about before, Andy, of what are those innovations? And what are the innovations that matter? And what are the innovations that maybe don't contribute as much?
So you're not worried that we're going to not find cures that we would otherwise find as a result of this negotiation?
And I think that this can really drive the kind of innovation that we need. But I will say this is also why, to your point of being able to implement well, this is why it's been so important to us from day one to have monthly meetings with manufacturers, monthly meetings with health plans, strategic conversations. We have an open door because, exactly to your point, Andy, we want to make sure that we are thinking through all aspects of this. It's very complex and very thorny, and we want to try to avoid any unintended consequences.
You do get high marks from everyone for being very open and transparent, Meena, which I think is incredibly important. There's also this matter, and I know you can't speak to it, of a lawsuit saying that you're violating their First Amendment rights, the way this negotiation is going on. I know you can't speak to the law and to the lawsuit, but is there something here that the public should understand about this line of thought?
Yeah, I'm glad you brought this up because, this is why we are engaging the way we are. And what I mean by that is we put out a draft guidance for kind of the rules of the road of how we'll do this negotiation process. And we got very robust comments from everyone on it, which is what we wanted, right? We want to get constructive comments. Okay, have you thought about this or have you thought about that? Could you address this issue? And issues were brought up, comments were raised about the negotiation process and can it be more transparent? That is absolutely something that we are taking into consideration as we work to revise this negotiation guidance, and put it out. And I will emphasize the constructive. For us, as you said, we are working very hard to engage with everyone, and engaging in a constructive way is the way that ultimately we're all going to be able to achieve our collective goals, right? The vision here is let's make drugs accessible, affordable, and that we're innovating for the cures and therapies that people need.
Okay, Ozempic and Mounjaro. Everybody knows what we're talking about here. Drugs that are approved for diabetes, but people are taking them off-label for weight loss, and there is a gathering body of evidence. Dr. Califf, who you mentioned from the commissioner of the FDA, talked yesterday much more positively than I actually thought he would about the evidence, suggesting that there is a benefit and that those benefits outweigh whatever risks there are in his mind, although people are still collecting data. But the decision about whether or not people who don't suffer from diabetes can take these drugs is a big one. And many of that decision really begins in some ways with what Medicare does. So how should we think about that?
Yeah, and what Medicare does depends on what the Medicare law says, right? The Medicare law provides us at, say, the 50,000-foot level of here's what you can do and what you can't.
So what does it say?
So the Medicare law says that the Medicare prescription drug program cannot cover drugs for weight loss.
It says that in law.
Yes, it says that in the statute. It specifically has a carve-out for weight loss. And so I think it's an important, at an even higher level, this comes up not just with this situation, where I think sometimes people don't necessarily know the different parts that come together to create the Medicare program. There's the Medicare law at like the 50,000-foot level that gives us, it's what's called authority, to then be able to do regulations at like the 25,000-foot level of policies that then enables care to play out on the ground.
Yep.
So, this is where, one of the things that you mentioned is the ongoing evidence and ongoing data, because I think that is very important. We are working very closely with our FDA colleagues on this and other issues where, as you said, if someone has diabetes, that is something that can be covered, by the Part D program, and we're continuing to look at these issues and see where there are opportunities and what makes sense, because ultimately we all have that shared goal of where there is a treatment that is going to keep people healthy, that we are able to cover, how do we try to improve access?
So I'm going to ask one more question while the audience prepares its own questions, which we're going to turn to in a second. And it's really on that line of put aside those two drugs. There are lots of other drugs that would probably meet the definition of this would be really good for us to have, not just drugs, but diagnostics. There are new diagnostics that will tell you if you've got a solid tumor that will soon be available through blood testing. And you'd want everybody, based on the logic you said earlier, you'd want everybody to get that diagnostic test so that they didn't downstream get colon cancer, die early, and of course, cost all that money. Yet the cost of paying for it for everybody in the country would be more than $500 per person. So let me see if I do the math. We've got 64 million Medicare members times 500. Okay, that's a lot of money. So I want you to put aside the question of what the law says you can do for a second and to talk about things what the law says you actually can do if you want to. I just want to know how you think about how we as a country should be thinking about these things that are good, but super expensive because so many of them are coming down the pike?
Yeah, that's a great question, and I think it is to some of what you said, where if you can, what we call move care upstream, where you can address things earlier, there is that huge benefit for society and for preventing people from getting sick and costing money down the road. And so, it really is both sides of that equation of keeping people healthier and spending money in a smarter way, where you're spending money that's going to keep someone healthy rather than they get sick and then after the fact you're trying to
But how do you do
fix
that? But how do you do that when you've got drugs that maybe can prevent things very early, diagnose things very early, but they have to go to a broad population because they're very hard to target, and therefore they'll cost billions and billions of dollars? How do you do that? Because it would achieve that goal, but it would do so at an incredibly high expense. How does Medicare think about those decisions? And those decisions relate to Alzheimer's, they relate to prevention, they're all over, and they're just going to get greater and greater.
Well, and I think this comes back to some of what we were talking about also with the changes that are happening in the drug space with the new drug law, right? Where we can kind of incorporate some of the impacts of these drugs when we think about our negotiation process. It also comes through just in the drug plans of how formularies are created, right? If you know formulary where there could be a preferred drug that has a lower out-of-pocket cost for people or a less preferred drug, these are all ways that the healthcare market, because we are not the only people engaged in this, health plans are as well, that we try to address this kind of issue.
Okay, I don't think any of us are satisfied that is a resolved question, but it's a tough one.
Well, no, it is a tough one, and this is kind of an ongoing.
So let me ask the audience now, two favors. One is wait for the mic. Raise your hand, please, if you want to ask a question. Wait for the mic. And then secondly, try to be very brief because we want to get through a few more questions possible. Go to the back, gentleman in the white.
Thanks so much for a great talk. I'm Connor Sheehy with the Senate Finance Committee on the side that's probably less popular in this room, as you know well. I wanted to ask you about the last piece you mentioned with respect to the role of health plans and pharmacy benefit managers in their formulary designs. We're seeing a lot of patients paying based on the list price and a number of other PBM practices that are actually blocking access to lower cost biosimilars and other drugs. There's bipartisan interest on the Hill. I was just interested in what your agency's thinking in terms of how to tackle some of those misaligned incentives that are ultimately blocking patients from accessing drugs that would cost them a lot less and improve adherence.
Yeah, thank you, Connor, for your question. One of the things that we do in the Medicare program is we review all of the formularies for all of the Part D, which is the prescription drug program. We review all of the formularies from all of the plans to make sure that they are clinically appropriate, to make sure that they are not discriminatory, because to pick up what you said, Connor, if you have a formulary that, say, is making drugs for HIV very difficult to access, that is discriminatory, right? Because it is going to discourage people with HIV from enrolling in that plan. So we have a whole team of pharmacists, et cetera, who go through each formulary to make sure that it is clinically appropriate, that it is not discriminatory and ensuring access. Okay. That being said, there are always avenues for improvement, and as you know, we are providing technical assistance as the Hill. I'm getting applause, by the way, from Connor right now. We are providing technical assistance to the Hill as they are thinking through these issues. It comes back to Medicare law and what that allows us to do.
And you can finish that up in Washington, I think. Let's go to the gentleman in the navy jacket right there.
Hello? Okay. Hello, good morning, Meena. Arthur Evans, I'm from the American Psychological Association, and I was glad to hear you talk so much about prevention, working upstream, and as you know, our current financing system does not allow for a lot of the kind of work that you're talking about. So I'm really wondering what you're thinking about alternative payment arrangements, how big of a priority is it for you and the administration? And if you give us a sense of timeline of what you think could get accomplished during your tenure.
Yeah, thank you, Arthur. We really are thinking about payments that can reward like team-based approaches to care. So an example with psychologists. We now will pay for psychologists who provide behavioral health as part of a primary care office visit. That's just one example of what we're trying to do so that, again, we care for people as people, not treating some specific disease in a silo.
Let's go to the next question. I think there's a woman over there in the pink, and you right there, yes.
Thank you so much. My name is Emmy, and I'm with Healthcare Without Harm. Recently, the Joint Commission introduced some voluntary environmental sustainability standards, and I just wanted to ask, especially given the outsized impact of climate change on the Medicaid population, the Medicare population, and its intersection with the two priorities you named of behavioral health, rural health, how is CMS thinking about climate change and taking that into account?
Yeah, I don't think your mandate's big enough. Take a climate for us.
Well, I think your question is a perfect example of how we all need to be thinking about health more broadly and what impacts health. And to come back to, Andy, something that you and I talked about, we have to think about what our levers are in our authorities in the Medicare program to be able to support that.
Next question. Up here, gentleman in the front.
Thank you. I'm Joseph Musgrave. I work in Ireland, so I'm just visiting for this festival. In Ireland, we fully fund long-term care, both home health aides and nursing homes. And I just wondered, given that the Medicaid program does fund some of that, but Medicare doesn't, what your thoughts are about the future long-term care needs and how to fund that in the country.
Yeah. So the question is around how are we going to fund long-term healthcare needs for the future? And I would ask you to take yourself out of the day-to-day of what you're allowed to do today, and maybe answer this conceptually as a healthcare policymaker and economist and physician. How should we as a country tackle a challenge like that?
Yeah, and I think, Andy, part of the reason that you're saying to take it out of today, because the Medicare law actually says that there's only certain situations in which home health is paid for. But I think overall, as a country, we should, again, be thinking about all of the ways in which we can improve people's health and really trying to drive those changes about care in the community and, thinking more broadly.
We have time for a couple more. Sandra Hernandez.
Good morning. Thank you for the conversation. Sandra Hernandez, California Healthcare Foundation. Given the severe workforce shortages we have, the way that we pay for GME still runs largely through hospitals and through our Medicare program. Is there any thinking in the administration, or are you thinking at all about how we rethink GME as we try to move people out of hospitals and try to get physicians and clinicians experienced in things other than hospital-based medicine?
That's a great question, Sandra. And actually, one of the provisions that I personally worked on in the Affordable Care Act was the Teaching Health Center program, which provides residency training in federally qualified health centers and community health centers to that point. And where we are using GME dollars to fund new training slots in rural and underserved areas.
So I want to say thanks to this great audience. Let's hear it for this great audience. I want to ask the audience, should we do more live shows? Okay, this is good. This is good. I want to thank Dr. Meena Seshamani for your service, for being in the line of fire, for handling that with such grace, for coming in the bubble. And I want to remind all of you listening, you can email me always at andy@lemonadamedia.com. You can also get an In the Bubble t-shirt, hat, or coffee mug by going to lemonadamedia.com/shop. What else do I have to tell you? I think I've told you the most important things. Tune in next week. We have another amazing episode. Thank you all.
Thank you.